thanks. Well, actually, the two things I would skip if I feel like somebody's overwhelmed is usually exercise activity and stress. Stress often I don't even bring up very much in the beginning just because until I have a relationship with a woman, doing the, Edinburgh or stress assessment, I find isn't all that effective. And exercise, a lot of times I leave off just because they're overwhelmed, Generally, I won't leave off blood sugar testing or a meal plan. Those are my must. But we all work in different ways, too. Okay. So usually with diabetes, we have these long definitions. Really, all I tell my women usually is either they don't make enough insulin or what they make they don't use effectively. I don't get too detailed because they're not going to remember this metabolism, blah, 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 right? Next. Oh, here. As far as diagnosis goes, I usually do pull this up for my ladies with gestational diabetes just to kind of show them where they fall, explain to them their diagnosis, how they ended up here, what the numbers were. This is like our guidelines from 2011, the latest and greatest, right? If they got an early screen, why they qualified, non-Caucasian, just, history of gestational diabetes and so on. If they passed the first time around early pregnancy and they ended up in later pregnancy, again, 24 to 28 weeks gestation. I like to pull the, this chart up where it shows insulin needs in pregnancy. It's actually got several lines here. The bottom green, the kind of thicker green one, is type 1 diabetes, because by the end of a type 1 pregnancy, where a woman doesn't make any insulin, has to take it all from outside, right? Has to inject it all. It is actually the lower line, because she'll just about triple her insulin needs by end of pregnancy. Somebody who's type 2 or gestational often makes more insulin. Yeah.
Okay.
But can't use it effectively. Am I seeing yours? Yeah, anyway, is the dotted line. So the dotted line is actually gestational or type 2. And if you look at that slide, there's a thicker kind of purpley line. That's for the later diagnosis of gestational diabetes, because I also have women come in, are sure their doctor made a mistake, testing them late, had missed it like they were supposed to in early pregnancy. And we usually talk about why they get tested there, if that's the case. So next slide. Okay, this one is kind of what happens with high glucoses and insulin levels. You can just kind of keep clicking here, Cynthia.
Okay.
Yeah. So, there it goes. High blood glucose levels. If it's before 8 weeks, it's associated with birth defects. I actually will use this with somebody who's higher educated. I had somebody not too long ago who was actually a researcher in diabetes. Not pregnancy, but talk about somebody who is way beyond what most of my patients knew, right? And I also will talk about insulin resistant, because that's most of our patients, type 2s and gestationals. If you have that combination, you get poor placental implantation, so that's your miscarriages. Fetal stimulation from the high sugars stimulates the fetus to make more insulin, their pancreas. Excess growth results from that. Usually that's third trimester, someplace around 32 weeks that really starts. If they're big, they need more oxygen. They make more red cells, and you end up with hyperbiliary, polycythemia. Let's see. More oxygen, you get intolerance of labor, particularly if you get a placenta that's not working well. High insulin also stimulates, delays organ maturation. Your high sugars will also be stored in the placenta. Do enough of that, you get a placenta that doesn't work well, doesn't transfer oxygen and nutrients, right? Then you end up having to make more red cells, and you end up with a kid who doesn't grow. Insulin resistance also associated with hypertension, PIH, good old, preeclampsia and eclampsia. We see more of that in our gestationals. And of course, you have that, you get poor growth. All of this reprograms things, turns on the genes at the wrong time. So we end up with kids who might be more obese, are more likely to have diabetes, and so on. So next slide. Again, I talked about normal because normal will reduce all those complications. Usually what I actually do draw is why treat GDM and have the perfect baby. I got my jelly bean baby, and it's in their belly. Very high tech here. It's easier to teach with drawings than it is to actually teach with written material. So mom has lots of sugar, and she's got some insulin, but not quite enough. So the baby starts making all the insulin they need someplace around 13 weeks. Lots of insulin causes excess growth. That's my little shoulders there. Delays lung and liver maturation. The placenta will deteriorate if there's too much sugar. It gets stored there and clogs up the placenta. So food and oxygen doesn't move as well. You might end up with a small baby, not the big baby, right? Cut the cord, baby's out, and I end up with a baby that might have low sugars if they were overproducing their insulin. And this is all I ever do for most of my moms, my gestational moms. I might even do this for my type 1s and type 2s, because the only difference with this is the high sugars cause birth defects. I'm not drawing birth defects, but that's one of the things, and easy enough to just say that. Next, glycemic targets. I'll talk to our ladies about that. This is something they need to know right away, and also gives them some direction on where they're going. I don't expect perfect. I usually tell them that. I expect less than 20% out of range is what we're aiming for, though. So, and the other thing is, all they're going to be doing is the first two, the fasting pre-meal, 60 to 89, and 1 hour post-meal, 100 to 129. Generally, I don't even talk about the 2-hour number. In fact, I'm not even sure if that shows up in the guidelines for care, but I do have women who work in places where they can't get out of and get their 1-hour numbers, clean rooms and so on in the computer industry. I'm sure there's some other equivalent of that in other factories. Bedtime, 2 to 4 a.m. blood sugars. This might be different from the first one you guys received, first PowerPoint you received. It's actually lower than it used to be, and I had left the old numbers on there. It's 60 to 99 overnight. Again, we're aiming for normal, which is less than 100 overnight, and bedtime. Basic meal plan is the next thing I go into. Again, something they're going to use immediately. I talk about it being a controlled carbohydrate meal plan, which means they're going to have to figure out what a carbohydrate is. I love all the trifolds and everything else because it's nice, easy. Pictures work really well. Even if you don't read really well, you can find the pictures. I talked to them about eating every 2 to 3 hours. Literally 3 meals, 3 snacks usually. Some women end up with more if they have really long days. And it's not unusual. A lot of our working ladies do. So how to fit it in. Can you eat at your desk? Can, you drink a glass of milk? We usually want less than 10 hours overnight. Again, some of my women don't sleep that long either, but I do have a few who do. Avoiding concentrated sweets. And we'll talk about what concentrated sweets are. It's interesting what people think what concentrated sweets are, because they see, since juice is healthy, it must not be a sweet. Well, it is. What do we have to pull out of their normal meal plan and substitute something for? Sugar substitutes in moderation. Generally, everybody wants to know what moderation is. 2 to 4 servings a day. It's not a lot. That's one of those little packets of fake sugar, right? And generally, with breakfast, I want them to avoid milk and fruit. Once in a while, I have somebody who has to have it, and we'll try individualizing, see what works. Because often it does work. And if it works, I'm okay. It's when it doesn't work that we worry about it. So, and of course, we individualize. I like to make it as simple as possible. I do have women who, if it makes it easier, they actually almost eat the same thing all the time. For a lot of people, that doesn't work. But if it does, more power to them. Let's see, next. As far as all the food guides and so on and handouts, it helps to have something to take home, to carry. Has to be the right language. Pictures don't always work, right? Right food. So it has to be ethically correct, because if they don't eat it, there's no reason to even look at the meal plan, because it's not what they do. I usually will talk to them about what they can do, what they will do. It varies from woman to woman. I remember when I first started doing diabetes and pregnancy, I was sure every woman wanted to have her kid. And, the kid was priority. And I know it's not that. They have a life, and it has to fit into their life. Also, things that help, color, visuals will help. I've done some work with learning disabilities, and, things like colors. Like when you start looking at food guides, I know it doesn't show up on our picture here, but they actually are really helpful for somebody who's got some disabilities, because you can go, it's interesting how colors work really well that way. And again, visuals. So if they can see the picture of the food, it's easier to make that connection in your brain. Something like 20 to 30% of adults are supposed to have some kind of learning disabilities. At the last one, I go on some of these learning disabilities sites. That's huge. They're saying we're finding more and more of it because we're actually looking for it now. We're used to not. But maybe that's a part of the problems with some of your patients. It's not all connecting. Nutrition facts. I like to do how to count carbs. So I usually will pull out a little instruction on what a total carb is, how to figure out a serving size.